Assalamu alaikum warahmatullahi wabarakatuh. I'm really sorry for a small delay. Uh, Today we will try to have a quick review about the main points related to anesthesia scenarios which they asked in the exam about eye and ENT. Um, just a second, please. Okay, so can yes, Wajiha, can you just start? What will be the concerns? What will be the challenges if you are giving anesthesia for an ENT surgery? Can you enumerate few of them? Anyone, please? Like shared airway, bleeding, which is difficult to visualize at times and difficult to estimate. Okay. Then tube can kink. Then um, you can say few of them specific to like nasal surgery, few of them related to tonsillectomy, for example. So, like in tonsil, when they put the mouth gag, the tube can kink. Okay. Then there are concerns related to throat pack. Uh, there are some cases in which there is OSA because of enlarged adenoids and tonsils. So this will be another concern. Um, there are some patients who will have if we just broaden our concern, there will be some surgeries related to some congenital anomalies like cleft palate, cleft lip. Okay, so if we just discuss about this bleeding, just a second, please. Aspiration, circuit disconnection. Okay, so if we just think about some other surgeries related to ENT, like for example, mastoid surgery, uh, then this tympanoplasty. So there are something like in mastoid surgery, for example, there is something special about facial nerve. So at times they are doing nerve monitoring. Okay. So similar to what we discussed with reference to neuro, there will be no muscle relaxant. Okay. After first dose of initial intubating dose of even rocuronium you can give, but after that you will not give muscle relaxers. Okay, so this is one thing, and same is true for this cochlear implant when they are placing cochlear implant. Okay, so there are a lot of things common here also. Whenever the vestibulocochlear system is involved, any surgery, so there will be more chances of PUNV. So same is true for middle ear surgery, or even uh, I'm not sure about tympanoplasty, but you generally middle ear surgery in which any surgery in which vestibulocochlear nerve is involved, there are more chances of PUNV in those patients. So these things should be in your consideration. What else? Hmm. Okay, Bilal, would you like to say something about ENT surgery with reference to any point you want to add on?
Maybe later, I am listening.
Oh, okay. Okay, so um, just a second, please. So let's see what we have. Just a second. There is some problem, I think. Yes, I think I'm signed out. No, get the. uh, Sorry for this inconvenience. Bilal, in the meantime, if you can, if you are able to speak out for 1 minute, let me fix this issue. I don't know what's happening.
Can you let me share one or two uh, diagrams, like infographics, which really needed for everyone who is working in ENT? Because I'm unable to share. They say host can share it.
Just a second, just a second. I think there is an option by which I can. Just a second. I think it's coming from the privacy. There is an option here. Just a second. You can share, I think. Bilal, are you able to share the screen now? Bilal, can you hear me? Sorry for this inconvenience. Just a second, please.
You can continue your job. I'll drop something there. I'm in
Uh,
OR, so I'm stuck with the
Bilal,
wall.
I have made it open. I think you can share.
Yeah, I'm struggling to pull those files. Let me do it. You just continue.
Okay. So we have stuck together. Actually, I'm not able to open my Google Drive, and you are not able to share. Anyways, apology for this inconvenience. So actually, any of the exam candidate, uh,
Yes, sir.
like yes, Zishan. So we have discussed few of the concerns related to ENT surgery. One of them is bleeding, shared airway, kink tube, PONV, OSA, nerve monitoring, and PONV in mastoidectomy, avoidance of nitrous oxide. Anything else you want to add on in
Sir,
surgery?
tracheostomy, sir? Yes, tracheostomy.
Yes, yes, tracheostomy. Yes, you are right. Like Okay, we will have a look for few words like tracheostomy and laryngectomy. In between, if you can just and anything to add for like concern with reference to adenoids, nasal surgeries.
Sir, positions and throat take like uh,
Throat
they are
pack we have
also.
discussed. Throat pack we have discussed. Throat pack, like whenever we, yes, very good. Throat pack, whenever it is placed, we have to document the time throat pack in loudly. Even the nursing staff note down the time of throat pack in, throat pack out, because there are incidents of retained throat pack and to be removed only in the post-op, in even in the ice, in the wards. So it can create airway obstruction. Okay. And with reference to
Sir,
bleeding tonsil, because we discussed bleeding tonsil earlier with when we were discussing the pediatric patient, but the same thing we will the bleed, because I told you that in these surgeries it's difficult to estimate the bleeding, because bleeding is patient is inhaling, so this bleeding may be concealed, and now you only have the parameters, the clinical parameters by which you can estimate that how much blood loss has occurred. Okay. And then if you are giving a second anesthesia, uh, it will be considered as full stomach as well as the baby will be anxious. Okay. Like you have to take a lot of care in like even the airway manipulation will be difficult. Maybe you need to have a smaller size, one size smaller tube because of airway engorgement. And these are things which with reference to bleeding tonsil. And one thing with reference to this nasal surgery is transfinital pituitary surgery is also considered is a like it's uh, combined ENT or neuro. Okay. And in those
sir,
surgeries,
what
in
about
that,
sir?
yes,
Sir, foreign body and pediatric inhalational or injection, sir. That
yes,
comes in
yes,
ENT, sir.
yes, it is also, it is
Sir,
also.
we also have special tubes like ray tubes for tonsillectomy, and then UNV risk is increased, and especially in ear surgery. Uh, and then if they use local anesthetic with adrenaline for faking or thing like that,
Yes, that may
and
be
then
in, yes, nasal surgery. They are also asking for uh, hypotensive anesthesia. So
hypotension. Yeah.
concerns related to hypotensive anesthesia will also come into account, or also laser. There are so many procedures in which laser is being used, especially vocal cords, or in case of tracheal obstruction. Sometimes they are using laser. They are doing tracheal dilatation procedures. With reference to laryngectomy, what important things should be in your mind? Because it's a cancer. So all the concerns related to cancer, okay, the metastasis, the local spread, chemotherapy, radiotherapy, bone marrow suppression, sometimes it's palliative care. These are common things. And especially here, because airway is involved, so a number of times these patients are coming with change of voice, hoarseness, and initially maybe they will be doing like bronchoscopy and taking biopsy. So even in these patients, sometimes it's difficult to pass the endotracheal tube, and it's better to have radiological evidence or MRI or nase endoscopy to see if you will be having any challenges for airway management. And even in these patients, sometimes they go for elective tracheostomy. Even for if you have any doubt, you will not make the patient, like it will be a challenging thing. So sometimes they are doing tracheostomy first, and then they are doing the biopsy, and because they want to have the clear diagnosis of the type of the tumor and for the prognosis. And maybe sometimes they are giving chemotherapy or radiotherapy before procedure to decrease the vascularity or decrease to have better outcome. So these things should be in your mind, okay, with reference to laryngectomy. Rest of the things will be the same, uh, like uh, if it's old age patient, concerns, like one of the reason of any cancer is smoking. So maybe concerns related to smoking, concerns related to old age, and rest of the things I have, some of them I have told. Yes, awake or sleep fiber optic. I would like to have words from Bilal because he's expert of these things. He can have few words about this uh, sleep fiber optic. Uh, okay, so okay, foreign body. If we because we discussed some points in pediatric anesthesia, we will just try to in if you have a patient for this foreign body, uh, how will you manage? Like, what are the things for your consideration in such patients? Anyone, please? Foreign body. If you want to evaluate a patient for foreign body, how will you evaluate?
Sir,
What will you do?
we would take brief history and examination,
Okay.
and we would concerns about the type of foreign body and its location, whether it is in upper airway or lower airway, and then
Mm-hmm.
of course its presentation important, that it acute or subacute presentation, like
Mm-hmm.
choking, coughing, sudden
In the
sudden
history, which is more
infection.
important? Like you have said, correct, like rightly. But what's important things in your exam history examination? What is more important thing? What will
Sir,
you
choking is important, and the change of voice like hoarseness,
know
stridor, wheeze.
as an
Uh,
anesthetist? What the word which will you will be saying that if there any sign of airway obstruction?
more obstruction, sir, is more important. It is impending. It is actually a situation which could lead to airway obstruction. It is impending airway
Okay.
obstruction situation.
So if there is
So,
any sign of airway obstruction, that will be haunting to
sir,
you, okay? And
yes,
some
of course.
because the sometime if you try to examine a lot, even taking IV line will be a challenge, and even the
Yes,
taking the patient inside the OR will be a challenge because if the baby cry more, maybe it can if partial obstruction can become complete, okay? And
complete obstruction.
among the history, of course, how it happened. Sometimes like because I have faced myself two times. One of my son was eating coffee and jumping um, on the sofa. So suddenly it went inside. I was not at home and fine. Well, like there are so many things which need to be care. But finally, my wife somehow she was able to pull it. She pull it out one of them, and the other son he put chicken pea inside the nose and in the same day. So like there are so many things. Sometimes it is concealed because she knew that he had it and he put it, so we did not see him putting inside. So a number of time history will not be clear. So maybe patient is having other signs, like patient is coughing, or patient is having secretions, or patient is having nasal like nasal congestion. So not sometimes clearly don't not mentioned, like you cannot pick. So in that case, and these things are usually radio lucent. You cannot even identify with the if it is some food like that, maybe it's not identifiable even with the radiological study. If it is a radio pack thing, only then you can identify if it's like coin or any metal or anything like that. And then maybe it is dissolvable or not. So material will also matter. Okay. So
Yes,
these are the things which you should be
And sir,
taking.
we should have close communication with the ENT surgeon and expertise of the ENT surgeon, and we whether we have to check with the bronchoscope there is a ventilating port or not, and
Very
at
good.
what time, what saturation we will take them from the ENT surgeon, and then we ventilate mass ventilation. These things are very important.
sir. But before that, we should check that patient is spontaneously ventilating. That is more important. The patient ventilation should not be compromised at any
Okay,
cost.
what will be the problem if it occurs? Like if you are trying to ventilate, what can occur?
Sir, it can obstruct the airway fully, and it can go forward as well. Sometime it depends upon it is in upper airway or lower airway. If it is in lower trachea, then sometime if the ENT or the surgeon is unable to take it out, then we can tell him that push it forward so that it goes to one of
Obstruction is
the
relieved. Like first
obstruction
aim
is
is
relieved.
to relieve the obstruction, and then
Yes,
like later on they can try to pull it out. Is it like this?
yes, sir. Yes, sir. And if an upper airway, then again our aim would be with minimal imaging, if we could able to localize it. If a surgeon has done it already, then we would try to locate that. Otherwise, then we would go to a minimum preparation, like we can give some injection, dexamethasone injection, glycopyrrolate, so that the airway edema and secretions are minimized. And of course, we would try to ventilate and oxygenate the patient at any cost. And rigid bronchoscopy is the gold standard. It should be available prior to airway handling in such cases. And then we would just sedate the baby or the child on spontaneous ventilation, but not paralyze the baby. Not, we would not give muscle relaxant. So, and then, like the colleague said, that the communication with the ENT surgeon, so that he or she is able to do it when the patient is ventilating. And we would also try to do suction meanwhile, as the suction port is attached with the rigid bronchoscope. Gentle handling is important in this case, in the airway foreign body case.
And you
Uh,
said why you don't
I
want to give muscle relaxant?
Sir, muscle relaxant, again, if it is partial obstruction and then we are unable to ventilate the patient, then we would lead to catastrophic situation.
If
Uh,
you
we
have
would,
if you have passed the
we would,
endotracheal tube and now they are doing the rigid bronchoscope through it.
yes, then we would give muscle relaxant.
Okay, so Bilal, this is what you want to just a second, let me save it. Review this one. Okay, just a second, please.
Then,
Okay,
of course, sir, post removal airway antibiotic and again ventilations monitoring for some upper airway bleeding is
pre-airway
important
management. Two.
to keep the patient
Okay,
monitored all the time till he fully recover, he or she.
okay, so Bilal has shared this. Actually, this is upside down, but I will try to read out like suspected difficult laryngoscopy or intubation with direct or video laryngoscope. Yes or no. Okay. So, like first, you will be that you will be able to have a laryngoscopy or through this video laryngoscope. If you have suspected difficulty, you will go to suspected difficult ventilation with face mask or supraglottic airway device. So these two things, and then third is aspiration risk and increased risk of rapid desaturation. Very good. So these 4 points you will consider your decision making. Okay. Your decision making will be either you have difficult ventilation, risk of aspiration, and a patient who is physiologically difficult airway. Actually, this word will be physiological difficult airway. Increased risk of the rapid desaturation. So actually, there was a tutorial also on physiologically difficult airway. So one of them point will be this one. So if these things are there, so they will you will go for awake airway management. Okay, and airway management with induction or anesthesia if you don't have problem with the laryngoscopy. Okay, any one factor alone assess difficulty with intubation or ventilation or aspiration may be clinically important enough to warrant anawake intubation. Yes, very good. Other patients factor may require an alternative strategy, patient instability and inability to cooperate. Okay. So this is a very good slide. So again, you will see difficult laryngoscopy either with the normal laryngoscope or with the video laryngoscope. Do you have any problem with mask ventilation? Even with supraglottic airway device? Okay. And then aspiration risk and a patient who is not able to tolerate even if a little bit of apnea and rapidly desaturating. So these are the things. Uh, I'm sorry, I don't know how I got stuck in this issue. I don't know. Let me try here because my Google Drive is not opening. Uh, just a second. Yes, Zishan, you want to add something?
Yes, sir. For fasting, sir, we should consult with the ENT surgeon how we can delay it, chances of any delays, so we can have a properly fasted child for this procedure, sir, for this rigid bronchoscopes.
No, in obstruction, would you say for an NPO?
Yes, sir.
In
Sir,
foreign body?
In
In
foreign body,
foreign
yes.
in foreign body, can you delay the surgery?
sir,
Sir,
he is yes, sir. Continue,
if
continue,
the
Zishan.
sir, if the airway, if the patient has not any severe symptoms, patient has foreign body, but his symptoms are not severe, and after discussion with the ENT surgeon, if could be delayed for few hours so that NPO time could be prolonged, sir.
Okay.
Sir, actually depend upon the presentation. He is right as far as this is concerned. Because even I myself here operated one girl of 17 or 18 year of age. She had the hairpin which was in the bronchus, and she had recurrent pneumonia. She had been treated for that, and then the thoracic surgeon had operated for that. So that the presentation could be asymptomatic, presentation could be subacute upper respiratory tract infection, or it could be lower respiratory tract infection, depends upon the location and the type of the material. And then the presentation is important. If the presentation is not that much challenging or alarming, that could lead to immediate airway obstruction. So then the preparation time we could get through the imaging and through the NPO, giving NPO status, IV line, consent, and then the position and the preparation of the OT and the rigid bronchoscope and things like that. And then what would be our approach? This could be again depend upon the case with which the foreign body or the child or the baby is presenting.
Okay. Actually, in the exam, you will not have that much time. Okay. You will have very less time. So you have to make your words more meticulous. Okay. So that will be
So,
one point you need to be careful. So actually, finally, I'm able to solve the problem. The Google Drive is open. So actually, the with reference to patient positioning, how they put a shoulder roll and then they extend the neck. Okay. And then one thing in actually in mastoid surgery, they are making a semi, they are tilting the patient. So actually one of the problem which you can have, it's an extra that patient will have a neck in this position for a long time. So patient can have a post-operative pain in the neck. So that will be indifferent, like you have to be considering this thing. And of course, if any patient has any neck problem in which you cannot have that position for a long time, so that will be also a consideration. Uh, Hypotensive anesthesia, we have already discussed. Uh, and Roy tube, PONV prophylaxis. Would you like to give TIVA or inhalational agents? Which is better?
The Tiva is better.
TIVA, like like the mastoid surgery, there is no problem. But of course, if there will be less chances of, because what are the anesthetic medications which are more associated with PONV?
Sir, uh, opioids,
Inhala-
opioids,
Opioids, inhalational
inhalational,
agents, nitrous
inhalational agent,
oxide, nitrous oxide.
nitrous, neostigmine.
Neostigmine, very good. Okay, so you will try to avoid as much as possible. And another anesthetic factor, which is very important, which is in your hand for the avoidance of PUNV. What's that?
Sir, we can go for
No, no,
regional, sir,
no, no,
avoidance
no.
of J.
Here, what will you do regional? In a mastoid surgery, you will do regional?
No, I was saying as a general, sir.
Astaghfirullah, please take care. Think about it. A very important factor from anesthesia, which is related to PONV.
Pain,
Other
sir.
than medic, go for simple things. What about fluid management?
Fluid.
One of the biggest factor for post-operative nausea vomiting is dehydration. If you keep the patient dehydrated, so this child will have a lot of chances of PONV. Pain, yes, if pain is also there, any unusual thing, like if it is so, but usually uh, pain, I am not sure about it. Pain, how will it cause PONV?
I think I read somewhere pain is a risk factor. Intraop, if pain, it is a risk factor of post-op PNV.
Okay, I'm not sure about it. It may be. Okay, and so like for controlling of blood pressure, your first line will be your anesthetic medications, good good control of hemodynamics. Okay, and then if you fail, then you go for medications like labetalol or esmolol, dexmedetomidine, magnesium. All of them they have written here for hypotensive anesthesia. And this meningotomy, meringoplasty, tympanoplasty, cholesteatoma surgery, stapes surgery. This is just common things which you they can ask you. A lot of things are common. Okay, if you have patient going for any congenital anomaly correction, one of them is this congenital hearing defects. So you can have any congenital anomalies together. So in like, maybe some syndromes. And similarly, uh, pediatric concern. Don't forget to mention about pediatric concern. Okay. So I think this is what they can ask you. Facial nerve monitoring, as I've told you, that facial nerve monitoring, and there's specific ways to monitor facial nerve. And in those patients, you will not be giving uh, uh, muscle relaxants. Okay. After intubating those, you will not give the muscle relaxant. So this is few words about EN throat ear surgery. Mm, We discussed few points about laser. I think about the laser. What question they can ask?
Airway fire, sir.
Airway fire, not airway fire. About the laser, what question they can ask? What are different types of laser? Just a second. Laser. I will open. There is a good article about laser. What are various lasers used in anesthesia, like in operation theater? This is also a topic which I don't. Mm, What is the name of laser? light amplification by stimulated emission of radiation. This is laser. Okay. And then there are monochromatic, that this is a single wavelength. Coherent, they are in same phase. Okay, if it is solid or liquid or gaseous, like so, it's in same phase. Collimated, they are in a line parallel. So these are the characters of laser. Okay, so they are monochromatic, coherent, collimated. Then there is a medium, whether it is a solid medium or liquid medium or gas. So here, gas are helium and CO2, and then liquid dyes and organ solvents, and solid maybe crystal or glasses. Okay, an energy source of pump maybe a high voltage discharge, a chemical reaction, diode, flash lamp, or another laser. And then optical activity consists of a cavity containing the lasing medium with two parallel mirrors on either side. One mirror is highly reflective and the other mirror is partially reflective, allowing some of the light to leave the cavity to produce the laser's output beam. This is called the output coupler. So, how this laser works? So, one metal in atomic physics describes an atom as a central nucleus of protons and neutrons, okay, surrounded by a cloud of electrons which encircle the nucleus in different orbitals. When appropriate energy is supplied to the atom, electrons jump from low energy orbital to high energy level, okay, leading to atomic excitation by the process of energy absorption. So some of the electron in high energy orbit spontaneously return to the ground state, releasing the difference in the energy in the form of a photon with a wavelength which depends exactly upon the difference in energy of the two states and has a random phase and direction. This process is called spontaneous emission. I think they are coming from going from one energy level to another energy level. I will repeat what is written. Some of the electron in high spontaneously return to ground state, okay, releasing the difference in the form of a photon. When it is coming from high level to low level, it will release a photon with a wavelength which depend exactly upon the difference in the energy. Okay, so spontaneous emission occurs and form the basis of light emitted by a neon sign, fluorescent light bulb, and television bulb. So this is the spontaneous emission which is causing all this. This emitted photon can collide with one of the mirrors in the resonating cavity and reflects back into the lasing medium, causing further collision. So they are coming back, and then this is creating the laser beam. If an excited atom is struck, it can be stimulated to decay back to the ground state, releasing two photons identical in direction, phase, polarization, and energy wavelength. So this is stimulated emission. So this is the basis of laser. So they are coming from one level energy level to another energy level, and then they are colliding with each other, and this is the three things. uh, Another concept is this: a cascade effect of stimulated emission of photons occurs, resulting in further amplification, okay, optical gain, and soon many of atoms emit light along the same axis. For a laser to sustain function, the majority of atom must be maintained in the excited state. Okay, so that's why that's how it will be maintained. So this is what is called as population inversion. This is achieved by continuous input from the energy pump, continuous wave laser, or by intermittent pumping result in a pulsed wave laser, because we don't use by ourselves, so we don't need that much knowledge. Unfortunately, in the exam they can ask you it. You will be very unfortunate because it's very difficult, it's not easy. I somehow cram it during the exam, but I'm unable to reproduce now. A small number of photons are allowed to escape from the lasing medium through the partially reflective mirror of the output coupler. This is usable laser light and maybe in the visible spectrum or beyond infrared or ultraviolet. It is
किसी भी किस्म
direct.
की अपडेट नहीं, डीएस में नहीं पड़ा।
Okay. Uh, This is the usable laser light and maybe invisible spectrum or beyond infrared or ultraviolet. It is directed to the target via delivery system, which consists of fiber optic light guides for visible light or series of mirrors for infrared. Actually, this is too much details, but usually you can recall few of the words that there is absorption of energy, then spontaneous emission, and then they stimulate each other. Okay, and then there is population inversion, so there the laser beam is produced. So this is how. Okay, so just a second. So usually they can ask you what are different lasers. So carbon dioxide laser, the laser which have high wavelength will penetrate more or less.
Sir, less, it's for superficial type of surgeries.
Yes, for CO2,
That was-
CO2 have is for superficial structures. Okay.
the NDOG is for deep penetration, like for stomach cancer or thing like that.
Yes, so ND YAG and this holmium YAG argon laser for retinal surgeries, they can ask these questions in the exam, in the MCQs, and in the Viva one time laser was asked to me, and Alhamdulillah I had failed the question. It is very difficult topic. I always try to run away from it, but somehow it comes again and again.
Sir, was
Mm,
it asked in table wire?
Table wire. And I was
Oh,
giving anesthesia without intubation somehow. So, we come out of the exam and we say the examiners very bad, they fail. But I can guarantee you that examiners they try to pass you. You are yourself the culprit to fail. Okay. And the questions which they can ask different types of lasers, penetration, their wavelengths,
sir.
okay, and this laser fire, sorry, airway fire. And what is the airway management? Just a second. Airway management in uh, laser surgery. Yes, yeah, I think there was a article with the different types of. Yes, you can see here the wavelength is the maximum, the penetration is the less. And similarly, maybe they can ask you a few of the uh, types. Uh, what are different types of laser tubes? It's not written here.
Sir, laser resistant type of tubes are there, and then most of the time those are metallic or laser flex type of tubes. If we
Okay.
don't have that, then we wrap the endotracheal tube with
Mm-hmm.
some aluminum foil. Or the other way, we put saline into the cuff of the or methylene blue into the cuff of the ITT tube, so that if laser rupture it, then we come to know.
There we put colored material as well.
Yes, sir. There could be methylene blue that is colored, no? Dark, dark color. Actually, our aims is to number one, we our goal is to secure the airway, like to put the laser resistant type tube, and then we have to provide the surgical field to the surgeon so that he or she able to do work. But our aim is to prevent airway fire and minimize airway trauma.
Okay, and if fire occur, what will be the step?
Uh, Sir, if fire occur, first we have to prevent, like we have to keep the very minimum FiO2 less than 30%. So if fire occur, we have to stop the FiO2 immediately. We have to stop the surgeon, and we have to remove the tube. We have to pull saline filled water that we have to, we should have kept it earlier, and then we have to re-intubate after doing bronchoscopy. We have to after intubation we have to do the bronchoscopy to see the damage of the airway.
Okay, so will there be any role of steroids?
The role of steroids is I don't think so. I have not read about, but if the airway edema we suspect,
So
then there is.
steroid will have role, I think, because it will decrease the edema. Okay.
Yes, sir. Edema, it is helpful, of course. Upper airway edema steroids have very good effect.
Okay. So this question they ask a number of times, and you should have a good grip about it. So
So,
let's. What about this cleft palate and cleft lip?
sir, cleft palate and cleft lip. Of course, first we have to evaluate for the congenital causes because like congenital heart disease, because the patient can present with some other congenital anomalies as well. We have to ask about the birth history and premature and natal antenatal history, of course. Patient, the mother of the baby has taken some anti-epileptic, anxiolytics or benzodiazepine-like drugs. And then we have to ask about what is the age of the patient and the baby has or a single cleft lip or cleft palate or both. And then usually the time for surgery is 3 months, 3 to 6 months for cleft lip, 9
Okay.
to 12 months for cleft palate. So for cleft lip and cleft palate, we have to prepare the child, and then we have to like other condition we have to do pre-anesthesia. We have to prepare that whether the patient age is appropriate, patient is not anemic, and patient would have feeding difficulties, and whether the patient is some respiratory infection or not. And if no other anomalies like some congenital syndrome, microgonithia, or thing like that, then we would prepare the patient. And we would consider as a difficult airway risk because the patient uh, tongue could retract and we would have some positioning issues as well. We would prepare after preparation of OT, after induction and intubation, we would put a ray tube and then we could have difficult mask ventilation before that. We could have difficulty in the laryngoscopy, and then the oral packs or throats are kept, and then we would measure for blood loss after securing the airway, putting the throat pack, and then we would hand over to the surgeon so that he or she is able to do.
How will you
Uh,
induce? How will you induce a patient with cleft palate?
Sir, cleft palate induction would be IV induction with inhalational
You are
technique.
saying that the patient you cannot ventilate, and you are saying IV induction.
Sir, we would assess first that how much it's like there are lip and cleft palate. It is of high arch, like could not describe it, that it is giving more difficulty in feeding or not. And then IV induction
Almost done, right?
IV induction is
Okay.
done, sir, if
We are
we are able
successful,
to
sir.
ventilate.
No,
If we
there is
are
an
unable
art.
to.
Just a second. I'm sorry. Again, please.
Sir, if the patient we are able to ventilate, then we would give
So
inhalational induction.
you will make the patient sleep first, and then you will assess how. So I think if you want to give a safe answer, inhalational induction will be a better answer, isn't that?
Sir, yes, sir. Of course, in toddlers or in infants, inhalational are preferred,
No, no, not because of this thing, because of
sir.
his airway problem. Okay. Because these
Yeah,
are the syndromes as written in the messages also. There are some syndromes which are associated. So which is Pierre Robinson with micrognathia and glossoptosis, yani like big tongue and small mouth opening. Okay.
Smart. Yes.
And in
Bed
fracture
liver.
colon, there is micrognathia and maxillary hypoplasia. So there will
Yes.
be that, and choanal atresia. So intumation may become more difficult with age. Uh,
Yes.
there are some. These two are, I think, more common: Down syndrome, microstomia, and relative macroglossia. Okay, congenital heart disease can be there in different types. I think these, at least the one two forms you should be knowing. At least I think these two and Down syndrome. Uh, so if it is that, the better answer will be Bilal. Would you like to say something, please? You had pointed out about these laser questions as well. I will just let's have a look on them as well. Just a second, please. Let's finish this. I think it's better. Easy way will be with the relational induction. Let's see what they have
Yes.
written here.
But I think first we have to check whether we are able to mask ventilate or not, and with inhalation
No, if
induction.
you are doing the mask ventilation, it means that you have knocked down the breathing. So this is not a good answer. That you, if you have any doubt, you will keep the inhalational spontaneous ventilation intact. You cannot say like practically we do whatever you do, forget about it. Practical is something else. But actually in this scenario, you cannot lose the spontaneous ventilation, because if you lose the spontaneous ventilation, you need to ventilate. So how can you take a chance that time? How will you evaluate? I hope you understand my point.
Yes, sir. I got, sir.
So anyone can disagree to me, but I think the
We can sir do check laryngoscopy.
check laryngoscopy here in this case. You see, this is what they have written as well. In general, a technique that maintains spontaneous ventilation should be chosen. Gas induction with a volatile is common. Ketamine given intramuscularly or intravenously is an alternative, but IV access, if not established, that will be a problem. But difficult mass ventilation is unusual, but should it occur, options include nasal or oropharyngeal airway, laryngeal mask, or turning the patient lateral or semi-prone. What they have written, but I think that safe answer would be maintaining the inhalational, spontaneous ventilation. Let's see what is written here as well. Okay, someone was
Sir,
also saying, sorry.
there is also another concern during this surgery. The surgeon use this instrument called, I think, Boyle Davis, that can cause tube obstruction, sir.
Yes, yes. Uh, uh, so, well, that was, it is mainly used for tonsillectomy. I'm not sure about here as well. Uh, there are
Yes.
different.
It's also,
I think
it's used over there as well. Most of the time, Dr. Shan is right. They hyperstretch or they overstretch the mouth for mouth opening, and then the tube kinks, and then it's giving us the problem. So most of the time we tell them that release some pressure or reduce its pressure so that the tube not kinks.
okay. So, uh, okay, just a second. Induction. Uh, You see here they have also written the same thing. Because in the exam it's better for you to have a safe answer rather than telling something which in which examiner can caught you. Okay. So let's see the messages from Bilal. Just a second, please. Okay, can we use high flow nasal oxygen in laser surgery?
Sir, in laser surgery, we use minimum oxygen usually. less than 30%, because in high flow
Actually,
oxygen it's
I don't have any experience about it. We would like Bilal to answer some of the questions about it. Okay, and what are concerns regarding FiO2 when and they are shooting laser? You have to minimize the oxygen. Why eye protection is required during laser? Because misdirected beam, it can damage the eyes. That's it, Bilal. How to proceed with the trach patients? What are the important points every day? They should ask if someone has tracheostomy. Tracheostomy, actually, tracheostomy. Let's open. We will have a look at a tracheostomy patient as well. But usually, I think it depends on how much duration has been elapsed. Because if the stoma is still new, it can have more problems if you are manipulating the tubes, and it can create foul passage. It can cause bleeding, so there are some, and as if the healing has been occurred, so later on, yes, like there may be some obstruction even due to scarring and everything, but usually that will be better tolerated than a patient who has recent tracheostomy. There is a full drill for blocked tracheostomy. Just open an article about it as well. But the common things till now which we have discussed. Uh, Adenotonsilly, we have discussed before. Cleft palate lip. Okay, let's open tracheostomy. Actually, tracheostomy will be two categories, like patient who are having any uh, uh, like facial fractures, or a patient like in which the ventilation uh, was not done, and patient need to have an emergency tracheostomy. Then a patient post laryngectomy, that will patient will have a tracheostomy. And if a patient is having prolonged ventilation and there is a risk of tracheal stenosis, so in that case, or even if sometimes the tracheostomy has not been done, but the prolonged ventilation, now patient develop tracheal stenosis, so you might need to do tracheostomy in that cases. So these are generally the indications, I think. And as if you are expecting a delayed ventilation, it's better to have early tracheostomy, because as you will delay, you see, what they have written here, after 6 to 8 days of laryngeal intubation, so they prefer to have uh, there will be reduced chances of even VAP, ventilator associated pneumonia. It will be decreased. So technique, one of them is percutaneous and the other one is the surgical. In percutaneous, actually they identify even nowadays, even the use of ultrasound may be helpful, or otherwise just they put a needle and then through it a guide wire is passed, and then gradually dilating, and like different people use different techniques. But even in this, if they are doing an elective tracheostomy, sometime we can place a glidoscope. Okay, so if a patient already has an endotracheal tube in situ, when they are withdrawing, it's easy to visualize with the glidoscope. So withdrawal of endotracheal tube becomes easy, and if there is any problem, you can immediately push it back. So that will be another advantage for it. Uh, okay. Tracheostomy care uh, depends uh, on the days. First change should not occur within 72 hours of tracheostomy being cited, and ideally not for 7 days after a percutaneous insertion. Uh, Okay, so you have to keep it humidified. Cold and anal filter aids an irritant and inhaled and can lead to increased production and viscosity of secretion. So you have to take care. That's why we cover it with a wet gauze. Features of tracheostomy tube, the diameter, the cuff, inner tube, fenestration. Fenestration is used for when they are trying to recanalize or they are trying to have this vocal uh, phonation. Flexibility, adjust, double flange. Okay, so immediate complications, aspiration, hemorrhage, air embolism. Air embolism, how? Any surgery above the level of heart? Big veins are there. That's, I think, failure of procedure, structural damage to the tracheal ring, intermediate complications like delayed hemorrhage, tube displacement, surgical emphysema, pneumomediastinum, pneumothorax, infection, tracheal necrosis, tracheoesophageal fistula. Yes, fistula creation can be there. And tracheosphagia, uh, tracheoarterial fistula or tracheoesophageal. Long-term tracheal stenosis, decannulation problem, and tracheocutaneous fistula. Disfiguring scar. There is an algorithm for displaced, how to manage this displaced tracheostomy. Immediately call for help and everything. If there is respiratory distress or high respiratory rate, decrease oxygen saturation. So this may be a reason of tracheostomy tube displacement. So usually what we do when tracheostomy tube is dislodged. Yes, Zishan.
Yes, sir.
Usually what we do.
Sir, we follow when the tracheostomy tube is blocked or dislodged. Sir, we follow this algorithm in which first we call for help and we assess whether the patient is breathing or not. If the patient is not breathing, then we go for the resuscitative measurement. But if the patient is breathing but is then we assess the patency of the tracheostomy, sir. First, uh, we remove the inner tube of the cannula. That is our first step, sir. And then after removal of the inner cannula, we assess the patient whether the condition improved. It is not improved, then we deflate the cuff. And even after deflating the cuff, the condition is not improved, then we remove the tracheostomy tube, sir.
Okay. And then what will be the options? You can try for another
Then if
new
the another, yes, sir, we can do another oral intubation, sir. But we will prepare a difficult trolley for it because
oral
it could be a
intubation.
difficult
How
intubation.
oral intubation will work?
सर मतलब sir, we can like perform either oral intubation or we can perform intubation through the stroma, sir. These two methods can be done, sir.
Yes. Um, and there are some incidents because actually this I'm not doing ICU for a long time, so that's why I didn't come across these things. We just handle it in a different way. Um, what about supraglottic airway device? Can we use it for ventilation through the tracheostomy?
I don't have no idea about this one, sir.
No,
Supraglottic
the patient is unable to ventilate through stoma and through
Yes,
endotracheal tube,
Bilal.
then of course,
Yeah, I'm sorry. Bilal, please speak out.
Yeah. So for the tracheostomy, the basic teaching is that when you are called for airway management with the patient with trach, every provider should ask three questions: which type of tracheostomy tube, was there or is there. Second question is that when tracheostomy was done. And third question is why tracheostomy was done. So first question is that which type of tracheostomy generally it comes two types of tubes, cuffed, uncuffed, and the one with the inner cannula and one with the outer cannula. So if why second question is important that when it was done, it tells you about stoma maturity. Usually they say that after 7 days stoma gets mature, and if tracheostomy tube falls out, for example, tracheostomy tube falls out after 7 days, so it's okay if you're expert to put it in without having a risk of creating a false space. And third question is that why it was done, because sometime if stoma is immature, it is recommended that we intubate from upfront, like oral intubation we do and we pass the stoma, because there is risk of creating a false space. But the third question, why it was done, because let's say it was done after laryngectomy. So in laryngectomy patient, there is complete closure of laryngeal inlet. So you cannot intubate from above. So these three basic questions save you from doing any error and to go to the right spot. And there are five common troubleshoots which happen with the tracheostomy patient. One is the choking of inner cannula due to secretions, which can be relieved with suction. Second is early fall of tracheostomy tube in immature stoma. The management is that intubate from the above. Third is that tracheostomy tube falls out in laryngectomy patient. In laryngectomy patient, there is less risk of creating a false space. You can put the Larry tube in anytime. If it's not possible, you can put size 3 eye gel or 00 size of pediatric mask over the laryngectomy stoma, and you can start ventilating this patient with positive pressure as we do during normal induction. In normal induction, we put a face mask, right, on the face. But in this scenario, we put a smallest size of face mask over the stoma and we ventilate the patient. And fourth scenario is false space created, which is usually accompanied by emphysema. And the situation is that you intubate from above and look the patient for the signs of pneumothorax. And fourth scenario is that in some patient, innominate vessel is quite high up in the neck. Our surgeon do a tracheostomy at low levels. Usually tracheostomy is done at the level of second, third, or first tracheal rings. So due to after a couple of days, usually after 15 to 20 days, that tracheostomy tip or cuff starts necrosing the innominate vessel and the patient present with profuse bleeding. In that case, again, if you see that pulsatile blood coming out of tracheostomy and patient is desetting, it probably it's an innominate vessel which is necrosed and started bleeding. So in that case, you just overinflate the cuff with 30 cc of air. If it doesn't work, you remove the cuff, intubate from above, and put your finger through the tracheostomy stoma and point it upwards to put a pressure. And if it's a nominate vessel, then patient and your finger goes to the OR till the cardiothoracic surgeon or ENT surgeon open the chest and they fix that vessel. So always three W's. Which type of tracheostomy? Second W, when it was done. Third W, why it was done. Thank you.
Please answer the other points you have raised about laser, please. If you can answer them as well. Like high flow nasal, will it be used in laser surgery?
Actually, high flow, if first question is that how many of you have used high flow? On high flow, we can control the FiO2. There is one knob to control humidity and one knob to control FiO2. In laser surgery, usually recommended that our FiO2 should be at least 30%, but ideally should be 28%. But on high flow, even you adjust your FiO2 level to 28%, but still it is not recommended to use high flow in laser surgery, because it's not about the FiO2, it's about the magnitude or number of the O2 molecules passing through the area where they are shooting laser. So still there is risk of airway fire, because with the high flow, usually flow is between 40 to 70 liter. So what I'm trying to raise the point that even if you decrease the FiO2, but number of molecules of oxygen which are passing through the area being shooted with the laser exceeds the safe number. So that's why still in case of high flow, there is risk of airway fire. So it's not recommended to use it in laser surgery.
Okay. Uh, and what about eye protection? The same answer was that it can
Yeah,
misdirect and
eye protection is that eye protection. Why eye protection? Because laser speed is more than our normal voluntary response. Like something blinks in our eyes, we move our head and close the eye. But laser speed is more than that spontaneous response. So if laser crosses your eye, there is a permanent blindness where it hits on your retina. So always we need to have goggles.
okay, Bilal, thanks for the expert words. Uh, so we
Okay,
have
you're
covered.
welcome. Thank you.
So we will just have few words about any more thing to be discussed with reference to ENT. Difficult airway algorithm is there. I'm just sparing it to be discussed with thyroid. But I think ENT, that's usually are the things which are being asked. Either they ask with this this nasal surgery, a cleft palate, cleft lip, or so few words about eye surgery before we finish. So eye surgery. Some of the aspects we covered with when we discuss about elderly patient for a cataract or a vitreous surgery. What about penetrating eye injury? If you have a scenario which they have given to you with reference to penetrating eye injury, what should be your response, Zishan? A, a young patient with penetrating eye injury.
Yeah, sir, in young patient, my anesthesia concern would be the NPO patient, sir. Patient would not be NPO, sir, and all the measures should be taken to not increase the intraocular pressure for the extrusion
You
of
know,
so that we can prevent.
Zishan, you are missing something very simple. I have told you whenever there any trauma comes,
Yes,
you have to say in your answer something.
sir. First, sir, we will start with the airway breathing and circulation and
Yes.
call for help, sir.
Call for help, and if there is any other injury, you have to rule out
Any other.
any other the mode of injury. Of course, penetrating eye injury they are saying, but you have to tell. It will not take few, not more than few seconds. So always make a habit whenever there is any trauma. Try to in your answer you start like that, because maybe they have something in their mind. Okay. Usually they
Yes,
will
sir.
not go in that detail, but you answer this in this way. The rest of the thing you will tell everything correctly. So, okay. So what will be next? What next?
The next, specifically coming to the patient with penetrating eye injuries, our main concern would be the patient will be full stomach, so risk of aspiration, and our anesthesia maneuvers can increase the rise in the intraocular pressure that can cause extrusion of the eye content outside, sir. So our main aim would be to prevent all those factors which can cause a rise in intraocular pressure, sir.
Okay. So what the same concern with reference to any emergency
Head,
surgery.
yes.
Just a second. I think it's anyway. So they can ask you about uh, what is different. I forgot what is e-visceration and e-nucleation. I don't remember, but I think you should know. What is e-nucleation and e-visceration, because there are two different things.
Sir, in evisceration, we remove the intraocular contents and preserve the eye as far as it is possible. Uh, and enucleation, the entire eyeball is removed, including some sclera and the muscles of eye orbital muscles.
Actually, I don't remember it. I just recalled because this is a question which they can ask. There was an article of blunt eye trauma. I don't know, penetrating eye injury. I don't know where it has gone. Um,
Penetrating eye injury, this question came into my table viva as well. It comes, you're right, so we have to know, sir.
Okay, so what about use of suxamethonium?
Sir, as far as like Zishan told, we have two main concerns: the airway concerns and the raised intraocular pressure concerns. So we have to intubate the patient to secure the airway, if because it's emergency situation. So we have to give the suxamethonium if we don't have the rocuronium option available, because rocuronium is not that increasing intraocular pressure. Suxamethonium is good, but it's increasing intraocular pressure as well. So if we have no choice, then we have to use it, because airway comes first, then eye.
Okay, so actually, you can minimize the rise in intraocular pressure by giving
Sir,
by regularization can
sir,
help.
yes, sir. First, we have to do all the measures, like we have to plan for smooth induction. We have to prevent cough, strain, vomit, or bucking. Of course, intra hypoxia, hypercarbia, these things, these all measures can increase intraocular pressure. So, as far as intubation is concerned, induction intubation is concerned, we have to deep the patient. We have to give, we have to make free, pain free the patient. We have to induce the patient deep with IV propofol, and then we have to relax, to give muscle relaxant, and then doing RSI, and then we have to intubate the patient along with suction.
So the rest of the things, a lot of things we have already covered in various discussions. So the same consideration will be here. So full stomach and risk of aspiration, this raised
Blunt,
intraocular pressure versus uh, versus risk of aspiration. And so these are the things which you can, because usually if it is available, rocuronium, this problem will be lost. There will be no problem like that. So okay, so they can ask you about some of the regional blocks. about you should be knowing the complications of retrobulbar, peribulbar blocks. Usually it's being done by the surgeon, okay? But you should be knowing few words about it, the reflexes, oculocardiac reflex, how to prevent. Is there any way to prevent?
Yes, sir, by deepening the anesthesia and give before induction, sometimes if there is more chance risk, we give glycopyrrolate, and when it happens, we ask the surgeon to stop traction on
I don't
muscles
think
of the.
so. Any of the maneuvers can decrease the chances of in oculocardiac reflex. Despite everything, it can occur. But of course, you can say that in what things in your hand are that the depth of anesthesia should be adequate, and as soon as it occurs, you have to stop the surgeon. And in some instance, I think the regional the blocks which they are giving, they can give some protection. I think, and uh, like there is no preventive role of atropine, that it's not needed to give atropine as a prevention. Okay. Uh,
Okay, so atropine is for treatment of it, not for prevention.
yes. So this is the complication of local anesthesia, retrobulbar hemorrhage, low penetration, optic nerve damage, local anesthesia toxicity, and muscle palsies. They have chemosis. So these are the, because in this maximum they will ask you what are different regional anesthesia blocks, and I think in retrobulbar it's facial nerve is all blocked simultaneously, and with peribulbar block you have to give separately. Am I right? Or I'm take saying other way around?
Yes, sir, you are right.
So it provides good anesthesia with complete akinesia. Okay. With peribulbar, you need to give separately. Uh, I think peribulbar or subtenon, you have to block the facial nerve separately. You just read this point. Otherwise, the concerns we discussed in the elderly scenario, anticoagulation patient is there. Sometimes patients are not able to lie flat. They have tremors. In that case, you need to give GA. Otherwise, commonly they are being done under monitored anesthesia care. Okay. And penetrating eye injury points we have discussed. Yes, all the eye medications. You should be knowing what are the effects of various eye medications. What are the common eye medications patient is taking? Beta, they are taking mediatric, okay, and they are taking beta blockers, they are taking antibiotics, they are taking steroids, okay. So if they are taking phenylephrine, for example, it can be absorbed and it can cause severe hypertension and bradycardia. If they are taking this mediatrics like atropine or cyclopentolate or tropicamide, it can cause tachycardia. Okay. And then steroids, they are also absorbed. So steroid maybe because it's relatively less amount, but it has effect. Similarly, beta blocker will have uh, heart rate, decreased heart rate. So, so you should be knowing the medication they are taking. Parasympathomimetic, it will also cause bradycardia. Okay. Uh, Diseases relevant to anesthetist. Uh, like there are certain age groups which are coming for certain various eye procedures. Okay. Trauma can occur in any uh, but uh, this cataracts and vitreous surgery, they are all usually the old age patient. Okay, and in pediatric patient, they are coming for congenital anomalies, including and also in which nasolacrimal duct is blocked. So dacryocystitis, what we say. So in these conditions, they are coming for uh, recanalization, or they are coming for examination under anesthesia. So these patients you should be taking care. And actually the squint surgery, they have some relationship with some neuromuscular diseases as well, or even there is incidence of I think malignant hyperthermia, some some incidents with it. So you should be just taking care about it. So I think we will stop here, inshallah. And
Body removal,
sorry,
foreign body, sir.
foreign body. Yes, foreign body also like trauma. So I will stop here, inshallah. We will discuss, because I think on the weekend I would like to have some discussion on ICU topics. I think Friday or Saturday. Tomorrow, let's see some of topic which we are remaining. I will try to do same time, inshallah. So okay, thank you very much. Inshallah, we will meet again.